Hi guys, welcome back. So today we're gonna do the last 3 papers that we haven't done yet. So I'm gonna start with paper 10. I'm sorry, the order is a bit all over the place because I'm doing it based on 9 people's requests. So we're gonna start with paper 10. So for the first thing that we need to be able to do is we need to examine the cardiovascular system. We need to perform precodium inspection, palpation, and auscultation. Alright, I think I've done this in one of the other videos. I can't remember which one. But let's just go over it really briefly. We'll breeze through this. So, precodium inspection. So things that you need to look for are things like any asymmetries in the chest, any deformities, any scars from previous surgery. So they have like an implantable pacemaker, any like lesions, any bruises, any ecchymosis, any visible pulsations, especially in the PMI. Just things like that. So precodium palpation. So we palpate for lifts and heaves, which are sustained impulses generated by enlarged chambers, specifically enlarged ventricles, that rhythmically lift our fingers when we palpate for these. So the way that we palpate for heaves and lifts is we just put our fingers flat on the second left and right intercostal spaces and the fifth intercostal space where the apical impulse is usually found. And then we palpate for thrills. So thrills are just palpable murmurs. So we palpate the exact same area, second intercostal space, left and right, as well as the apical area, but using the ball of our hands, okay? So just like so. And if we feel any of these thrills, we need to auscultate the areas where we feel them, just to actually listen for the murmur and help us identify the type of murmur. And then, is that it? Okay, for palpation, the last thing is the PMI. So we need to palpate for the PMI, which is usually located in the apical area, so the fifth intercostal space, mid-clavicular left-hand side. And we assess things like the location. So typically it's here, but in other conditions like situs inversus or dextrocardia, PMI may be transposed to the other side, which is the right side. And in patients who are pregnant, because the uterus pushes the diaphragm up, the PMI can also be pushed up a little bit. We also assess things like the diameter. So the diameter of the PMI should be between 1 and 2.5 centimeters when the patient is lying supine. It may feel a bit bigger when the patient rolls to his or her left lateral decubitus position, because in this position, the apex of the heart goes closer to the chest wall, so the PMI may feel bigger. And then the last thing is the amplitude. So the amplitude should be small. It should feel like a gentle tap. And if it feels diffuse, then this may suggest left ventricular dilatation. And if the tapping feels sustained and a lot intense than normal, then this may suggest left ventricular hypertrophy. And the way you actually palpate for the PMI is, the estimate location, so fifth intercostal space. So you use all your fingers, not all, but you use a lot of your fingers to palpate for it. And then until you can pinpoint the exact location with just one finger, okay? And I think that's it for palpation. Right, so we move on to auscultation. So precodium auscultation. So we have, different auscultation points. I don't know where my stethoscope is, but let me just show you. I'll point them to you. So we have the second intercostal space, right-hand side, which is the aortic region or the aortic valve area. Then the pulmonic valve area on the opposite side. So second intercostal space, left parasternal border, okay? The aortic one is second intercostal space, right parasternal border. And then we have the herb space on the third intercostal space, left parasternal border. And below that, so the fourth intercostal space, maybe the fifth as well, we have the tricuspid valve area. As I said, fourth or fifth intercostal space, left parasternal border. And then finally, we have the PMI, which is located at the mitral valve area, at the fifth intercostal space, mid-clavicular left-hand side, okay? So those are our auscultation points. And then moving on to the respiratory system, so we have to do anterior chest inspection, palpation, percussion, and auscultation. So inspection for 1 point. All right, so anterior chest, let's start with general things like observing the patient's rate of breathing. Normally it should be between 12 to 20. And then the type of breathing. Is it quiet breathing? Is it shallow breathing? Is it labored breathing? Are they using accessory muscles? Do they show any signs of respiratory distress, such as tachypnea, which means breathing really, really fast? We can also inspect the color of their skin. Are they pale or are they cyanotic, which then suggests that their breathing is not efficient with the level. Their breathing is not efficient. And then we could look at things like the AP diameter. If they have a barrel chest, suggesting hyperinflation of the lungs, such as in COPD. So barrel chest, the criteria has to be the AP diameter must be greater than 0.9. What else for general things? I think that's it for general things. We listen to audible breath sounds, like are there any added sounds or abnormal sounds like stridor, which can be a sign that there's some obstruction in their airway, wheezing, which can suggest the narrowing of the airways. So these you can even hear without a stethoscope. What else? I think that's it for just general things. So moving on to the actual anterior chest inspection, we start with the trachea. So we check if the trachea is still in the midline, and any deviation may suggest problems, like maybe there's a mass growing in the neck, or a large pneumothorax in the lung. And then after that, we look at the chest itself. Are there any deformities, any asymmetries in breathing, which can suggest like pleural effusion or again a large pneumothorax? Any scars from previous like lung surgeries, any drains attached to the patient, any lesions, any ecchymosis or bruises. I think that's everything for inspection of the lung. Also, retraction, sorry. So you could see retraction is another sign of respiratory distress. It's usually seen in asthmatics when they're having like a severe asthma attack. So there's suprasternal retractions and intercostal retractions, which means that bit of tissue there between the bony structures, they dip. They look like deeper as the patient is trying to like breathe, okay? I think that's everything for inspection. And then palpation, there's 3 things. So in the anterior chest, there's 3 main points we need to palpate. So 2 on the actual chest region and 1 on each side. So firstly, we need to palpate for any areas of pain or tenderness. We just ask the patient, is it tender there? Is it painful there? And then and then after that, we need to palpate for lung expansion. So we place our thumbs lateral to the costal margin. So imagine there's this person's anterior chest in front of me, and I place my thumb, like parallel to the lateral rib cage, and I ask the patient to take a deep breath in and out. So as they breathe in, my thumb should move further away from each other as the lungs fill with air, and when they exhale, my thumbs should go back closer together as their lungs expel the air out. So what we're looking for here is the symmetry and the range of the movements. So they should move symmetrically. If they don't, then this may suggest pleural effusion or again a pneumothorax. The range, so if the movement is very, very minimal, then this may suggest that the person has like interstitial lung disease or any forms of restrictive lung disease. And then the final thing for palpation is palpation for tactile fremitus. So tactile fremitus are just like palpable sound waves generated in the bronchopulmonary tree which is transmitted through the chest wall as the patient speaks. So we just use the ulnar surface of our hand. We place it in those on those three areas, and ask the patient to say 99 as they feel our hand touch their chest. So 99, 99, and 99. And increase in tactile fremitus indicates consolidation of the lung, or like change in lung density, which makes it more solid. So consolidation is like it happens when the air-filled space air-filled spaces of the lung gets filled with fluid or a mass like cancerous lesion that's growing inside the lung. So that will increase tactile fremitus. If there is decrease in tactile fremitus, this suggests that the sound waves are not traveling as efficiently from the bronchopulmonary tree to the chest wall, suggesting that the lungs are hyperinflated. So decrease in tactile fremitus may be seen in patients with COPD, for instance. And then we move on to percussion. So with percussion, we percuss in a ladder-like pattern, okay? And there are 6 percussion points in the anterior chest, as opposed to the posterior chest where we have 7, okay? So I'm just gonna show you where to percuss. I'm not actually gonna do the actual percussion. So we do it there. So we start at the apex of the lung, which the apex is kind of like, it starts maybe 2 to 4 centimeters above the clavicle. So you percuss there, and then there, and then there. So it's 2, 3, 4, 5, and 6. Okay, just to recap: 1, 2, 3, 4, 5, and 6. Okay. So the things that we look for percussion is like the resonant percussion notes. So normal healthy lungs are resonant. If there's any dullness, again, this indicates consolidation or just the fact that there's an organ underneath, or like a mass or cancerous mass that's growing inside as well, that can cause dullness. Moving on to auscultation, again, we auscultate those 6 different points in the on the anterior chest. So we ask the patient to breathe in and out through their mouth, because breathing in through this eliminates the risk of breathing in through an obstructed nose, which may introduce abnormal sounds when we hear on the stethoscope. And we also need to place the stethoscope directly on the patient's bare skin, because placing it on top of clothing may introduce, again, abnormal sounding sounds. So again, the 6 different auscultation points. So 1, 2, 3, 4, 5, and 6. Okay, similar to percussion. And we look for things like the breathing, the type of breathing. So normally it's vesicular breathing, which means that it's low in pitch, it's soft, and inspiration is greater than expiration. The abnormal ones are bronchial breathing and bronchovesicular. They're only abnormal if heard further away from the main airways, like the trachea and the mainstem bronchi, but otherwise they're normal if heard over the main airways, okay? We also listen if there are any adventitious breath sounds. Adventitious breath sounds are added sounds that are superimposed on the normal breathing sounds. So we have things like wheezing, crackles, we have stridor, pleuritic, like pleural rub. So yeah, those things. And if we hear any adventitious breath sounds, we need to test for transmitted voice sounds, including egophony, bronchophony, and whispered pectoraliquy. Right, so moving on to the abdomen. So for the abdomen, we need to be able to percuss and palpate the liver, and then perform the Murphy sign. So liver percussion we typically do to estimate the borders of the liver, which would help us kind of estimate the size of the liver. Okay, it would give us an idea if the liver is enlarged. So To identify the superior border of the liver, what we need to do is we locate the midclavicular line, and then we start at the level of T4, and then we just percuss down until we hear like a change in the percussion note from resonant, because the lungs are here, to dullness. Okay, so let's say that I hear dullness here, so I mark that area there, and then again, starting from the midclavicular line, but the level of the umbilicus, we percuss up to the until the percussion note changes from tympany, because the abdomen is usually tympanitic, to dullness, and then mark that point. So now I have these 2 points, and the distance between those 2 points should be between 6 and 12 centimeters. If it's anything bigger, then this suggests an enlarged liver or hepatomegaly. Is that it for percussion? I think that's it. And then we move on to liver palpation. So to palpate for the liver, sorry, I don't know why I'm doing it on this side. This is my left side. So I was meant to do it on my right side, guys. But okay, just imagine I did it on the right side. The liver is on the right upper quadrant. So I should have done it on this side. I don't know. Sorry. Right, let's do palpation properly then. So the liver is on the right upper quadrant, which is here. So to palpate for the liver, we have to put one hand behind the rib cage, and one hand we palpate the costal margin. We basically press down to the liver, okay, and ask the patient to take in like a deep breath. And what that does is it expands the lung, pushes the diaphragm down, and pushes the liver down a little bit. So we are able to feel like the liver edge. Don't get too upset if you can't, because most of the liver is tucked away anyway because of the rib cage. So and normally you shouldn't feel the liver anyway, but it's possible to do so. And if you do feel the liver edge, you need to assess the contour and the texture of the liver edge. So it has to be smooth and not nodular, okay? If you can't palpate it in this way, what you could do is the hooking technique. So this is applicable to patients who are a bit more overweight. So what we do is we hook our fingers along the costal margin, and again ask the patient to take a big breath in and then out, and feel the liver edge brush across your fingers as you do that. And then I think that's it for palpation. So Murphy's sign is actually a sign for cholecystitis. It's a test for cholecystitis, which is the inflammation of the gallbladder. So the gallbladder is, sorry, my throat. So the gallbladder is like in a similar location, so right upper quadrant. So what we do is we again do the hooking technique, and we ask the patient to take a deep breath in. Okay, positive sign for Murphy's sign is the rapid cessation of inspiration as you're doing the hooking technique, because in patients with cholecystitis, you know, when the diaphragm pushes the gallbladder down and it brushes against your fingers, it would be painful for the patient. So they would stop breathing, you know, in attempt to like stop the pain. Okay, so that is positive Murphy's sign. All right, moving on to the nervous system now. So we need to perform coordination tests, okay, for 5 points. So we have rapid alternating movements, point-to-point movements, gait, Romberg test, right? So rapid alternating movements we could do on the upper body and the lower body. So for the upper limbs, we could strike one hand on the anterior thigh. Well, ask the patient to strike one hand on the anterior thigh, turn it over, and then strike the back part of the hand on the same space, or like on this, around the same area, and then do that repeatedly as fast as they can. Right? You can't see what I'm doing. So imagine this is my thigh. So this is all that I'm doing. And then ask them to do this as quickly as they can. And normally the patient should be able to do that. But if there's any like cerebellar disease, the patient, so here we're looking for the speed at which they can do it, the smoothness of the movement, and just the rhythm. So in patients with cerebellar disease, it will be slow, the rhythm would be irregular, so it would look kind of like this. So it would be like that. You get the point. So there's another one actually. So for rapid alternating movements, we could also use the fingers. So we can ask the patient to touch the thumb, to tap the thumb, like with the other fingers in a specific sequence. And we encourage them to do this as fast as they can. Again, if there's no damage, if everything is working perfectly, if there's no damage in coordination, they will be able to do so without any problems. You have to do this on the other side, by the way, guys. So yeah. And if there is cerebellar disease, then they would be unsuccessful in doing this. And to test for rapid alternating movements with the lower limbs, you just ask the patient to tap the balls of their feet to the ground or to your hand, and encourage them to do so as quickly as possible. And again, you're looking for things like the smoothness of the movement, the speed, and the rhythm. So the next one is point-to-point movement. So point-to-point movement, again, we have the upper limbs and the lower limbs to test for this. So point-to-point movements, we ask the patient to touch their nose and touch our finger, but we're changing the direction of the finger, okay? And ask the patient to just follow your finger, okay? And obviously normal result, they would be able to do that, and abnormal, they would be unsuccessful. And then we have the other one where you just have your finger in, like, you hold your finger in one position, ask the patient to, sorry, I need to click my fingers, sorry. Okay, so hold the finger in like one place like that in front of the patient, and ask the patient to touch your finger and then move their arm overhead, touch the finger, move the arm overhead, touch the finger, move the arm overhead, like several times. And then you ask them to close their eyes and perform the same thing, okay? Try again like several times. And they should be successful in touching your finger. And obviously, an abnormal result is they'll miss the finger. And this happens because incoordination actually worsens when their eyes are closed in patients with cerebellar disease, okay? And then to test point-to-point movements with the lower limb, you ask the patient to basically touch one of the heel of their foot to the knee of the opposite leg, and run it down to the big toe, and do that several times, and then ask them to close their eyes. And normal, again, they would be able to do so. They'll put their heel on the knee, on the opposite knee, and then run it down to the big toe, no problem. If it's abnormal, what you would see is that their heel may oscillate side to side, might fall off the shin, they may lift the heel, or they may peek and cheat and look as to what they're doing. So basically they won't be able to do this because, as I said, incoordination worsens when their eyes are closed, okay? And then we assess gait in the context of coordination. So we have three tests. So we ask them to do three different types of walking. So the first one is tandem walking, which is walking heel to toe in a straight line, okay? And the next one is walking on like the balls of their feet, testing for balance, and the plantar flexion, and then ask them to walk on their heels, right? And this again tests balance and dorsiflexion. And then Romberg test. So Romberg test is like, so you basically ask the patient to stand upright with their feet together firstly with their eyes open, and then you ask them to close their eyes and hold that position for 30 to 60 seconds without any support, without holding on anything, or without you supporting them. And a positive Romberg sign means that, for instance, they're able to do it with their eyes open, stand upright with feet together, but then they lose balance when they close their eyes. Also, in worse cases, in patients with cerebellar ataxia, they would be unable to stand upright with their feet together even when their eyes are open. And again, it gets worse when their eyes are closed. So this is everything for paper 10, guys.